Hello and welcome to the third and final segment of our CME accredited video discussion entitled Community Oncology, Clinical Debates in Breast Cancer, Advanced Estrogen Receptor Positive Breast Cancer. I'm Dr. Harold Burstein, an Associate Professor of Medicine at Harvard Medical School, and I'll be your moderator for this educational activity. I'm delighted to be joined today by Dr. Stefan Gluck, Distinguished Professor at the Sylvester Comprehensive Cancer Center at University of Miami. Welcome and thanks as always for joining us.
Thank you.
The following learning objectives will be met upon completion of this accredited video segment. You'll be able to examine current data regarding the mechanisms of endocrine resistance and the rationale for therapeutic strategies to overcome resistance. You'll identify current, emerging, and investigational therapeutic approaches for refractory ER-positive breast cancer, including endocrine therapies and combination strategies using targeted agents. You'll be able to explain common crosstalk between ER and other growth factor signaling pathways and the possible rationale for targeting these pathways in advanced ER-positive breast cancer. And finally, you'll be able to describe the efficacy, safety, and tolerability of novel and emerging therapies that have demonstrated value in recent clinical trials. Let's start with a discussion really focused on the optimal therapy for patients with advanced or metastatic ER-positive endocrine-resistant breast cancer who've progressed after previous lines of endocrine therapy. And to help us with that, I had a case from my clinic recently. This is a 64-year-old woman who is being treated for advanced ER-positive breast cancer. 14 years ago, she received AC chemotherapy for node-negative breast cancer, and she experienced chemotherapy-induced amenorrhea at that time, and then received 5 years of adjuvant tamoxifen. 3 years ago, or roughly 10 plus years after her diagnosis, she was diagnosed with recurrent breast cancer to bone and lymph node. She began treatment with bisphosphonates and an aromatase inhibitor. She had tumor control for around 2 years, but then had tumor progression and began fulvestrant therapy. Roughly 10 months later, she again had evidence for tumor progression with increased bone disease and enlarged axillary, chest, and abdominal lymph nodes. She has some mild degree of bone pain in multiple locations and is fatigued, but otherwise feels quite well. So what are the treatment options for a patient like this who has refractory, ER-positive, advanced breast cancer? Stefan, let's first talk historically about what the options were for patients who'd already had tamoxifen in the adjuvant setting or had progressed on one line of endocrine therapy.
Well, as we all know, sooner or later this woman will need chemotherapy, and our goal is to avoid or delay as much as possible. So looking into alternative, other different endocrine treatment would be beneficial. And of course we had megestrol acetate, we had aminoglutamide, which we probably don't use anymore. We had actually high-dose estrogen. So these are options that are still out there for her, and they may be good for a period of time, but maybe at the same time quite toxic.
Let's just build on that mention of high-dose estrogen. In the 50s and 60s, there were reports of people having tumor responses to estrogens. I credit Matt Ellis for reinvigorating this question in the 21st century. He has done some very nice little studies exploring intermediate or higher dose estrogens and shown some clinical responses in refractory disease. Is that something you're pursuing with your patients?
Well, when these studies were presented by Matt Ellis, initially I tried on a couple of patients with mixed success. The problem is with estrogen, it does have side effects. Particularly the higher dose has lots of veno-occlusive disease, DVTs, and all the endocrine side effects. So it's not the best approach that one would do. And I would argue if one uses, in such late cases, gentle and cautious dose chemotherapy, it has actually less side effects.
Interesting point. So, but it is it's an old trick that maybe once in a while for well-selected patients might be an interesting option. You know, in the modern era, we're usually choosing between, say, an aromatase inhibitor and fulvestrant for tamoxifen-treated or de novo disease. In the woman who's already been on a non-steroidal aromatase inhibitor, such as this patient, what would your choices be when making that next decision at the time of progression?
Well, there's a study actually that gives us some guidance. I'm saying some because the doses are not quite what we do today. So the study is after non-steroidal aromatase inhibition. When the patient progressed, they were randomized to receive a steroidal one, exemestane, or fulvestrant.
This is the so-called EFFECT trial.
Correct. And it was dosed 25 milligrams for exemestane and 250 for fulvestrant, completely equivalent outcome. So at that time, I used to ask the patient, do you prefer to stay on a pill a day, or do you prefer to be off these pills that you may or may not forget, and she will tell me, and have a monthly injection in your buttocks? So IM injection. And in my experience, 8 would say, let's keep the pills, and 2 out of 10 would say, let's switch to injection.
You know, I know these data, and I would only just add that they didn't use fulvestrant, but we might now have used a regular dose of 500. I don't know how critical that was. In my own experience, I've seen what I think are somewhat better results with fulvestrant in this setting. I still try the aromatase inhibitors again, but I rarely see a major clinical response in that setting.
Indeed, I would agree. The response rates is still very low, but you can get a several months of progression-free or non-progression of disease rather than a response.
So the hot stuff here has been looking at
Yes.
the interactions between estrogen receptor and other growth factor pathways, and in particular the mTOR pathway. And so tell us just in brief about the science of those interactions before we launch into the clinical data.
So as we are learning more and more biology, of course the signaling, as we call it, of a cancer cell consists of a number of steps. And these steps are both serial and parallel. So there's a number of pathways that we are able to block. Many, not all, many of these pathways actually go all the way down to the so-called mTOR inhibitor, mTOR, which is one of the latest or very late pathways compounds that are just prior to translating the message of these proteins into the cell nucleus and tell the cell divide, grow, and be cancer. So the idea was, if one could target mTOR, one of those signal transduction pathways, one would have an advantage. This is particularly true for the EGF receptor superfamily pathway and for the ER family of pathways. Why I'm saying family? Because the estrogen receptor is not only genomic in the cell nucleus, but also, as we have learned 7-8 years ago, also in the cytoplasma, and is also going through the mTOR pathway before it reaches the cell nucleus.
And there was some data that as the cell became more resistant to traditional endocrine manipulations, that perhaps the mTOR pathway was upregulated, or somehow the cell was more dependent on that pathway.
Correct. And these pathways actually are talking to each other. We call it crosstalk. And if one is suppressed, the other one goes up and drives the pathway, again, against our inhibition, which means that it might be beneficial, and we have studies now that it is beneficial to target actually both.
So let's talk about those studies. The major publication and subsequent FDA approval was looking at a study that took women who had previously had anti-estrogen therapies with tamoxifen and fulvestrant, and had previously had a non-steroidal AI. Mm-hmm. These patients were offered exemestane, the steroidal AI, with or without everolimus, which is the commercially available mTOR inhibitor. So that was the Bolero study, and tell us those results.
Well, the Bolero study, Bolero 2 to be precise, is quite astounding. And why is it so? If data were analyzed with central review of responses and duration of response and time to progression, there was an astounding advantage of time to progression of 7 months, more than half a year, more than exemestane alone. This is almost unheard of in metastatic disease of breast cancer. 7 months is huge. More importantly, all subsets that were looked at, whether it was the age, the distribution of metastases, the number of metastases, receptors, including progesterone receptor, all subsets benefited significantly from the addition of this mTOR inhibitor. By the way, this mTOR inhibitor, everolimus, is already approved or has been approved for other diseases such as renal cell cancer.
So I don't want to throw ice water on this, but the central review might overstate it. The investigator-reported benefit was a little more modest.
Yes.
And in ER-positive disease where there's a lot of bone lesions, cutaneous disease, lymph nodes, that might be relevant. But clearly, it looked like it made everolimus, made exemestane work better. Now, the response rates were still pretty low, right? The response rate for exemestane alone was like 1%, and for the combination was about 10%,
12%.
12%.
Yeah, exactly.
And there was a related study, the so-called TAMRAD trial, that looked at tamoxifen with or without everolimus.
Yeah, it was a smaller study. It was a study which looked at the reversibility of the resistance to tamoxifen and showed not quite as astounding, but still positive data, including survival benefit. But I believe it was only a randomized phase 2 study.
It was a smaller study.
Yes.
So One of the things that breast cancer specialists probably want to learn about are the side effects of these new drugs like everolimus. So what are the major adverse events? Certainly pneumonitis, rash, mucosal irritation, and there is also some risk of hyperglycemia with all of these drugs that have some impact on the PI3 kinase pathway.
Yes.
So are you using this? This was FDA approved a month ago. It's a commercially available product. Is this the kind of thing you're routinely offering to patients, or how are you integrating these data into your practice?
I think that's the key which our audience wants to know. How should they use the drug? And indeed, I use it occasionally. I don't use it always. Why not? And the same answer is to balance your side effect profile versus benefit and versus quality of life. If a drug like everolimus gives you bad mucositis, and you mentioned the side effects already, which prevents the people from eating, from thriving, is painful, then you don't do a good job in continuing to improve quality of life. You still prolong her disease-free survival. Now, whether or not one prolongs survival is still an open question because the final overall survival analysis is pending. Pneumonitis, very rare, but if it happens, it's a reason to hospitalize a patient for a period of time, taking away from her life. So if a patient has a fast progressive disease, if a patient has symptomatic disease, and if I want to avoid chemotherapy, that will be the case where I use exemestane with everolimus.
Interesting. So trying to balance the side effects, the likely side effects, and the likely benefits. Now, there was an older study of first-line treatment of patients with ER-positive advanced breast cancer where they got letrozole and a randomization to a different mTOR inhibitor, temsirolimus. That study, which was presented 5 or 6 years ago at San Antonio, was a flat negative study. It's never been published, to my knowledge. What might account for some of the differences between those two sets of observations?
On the spot, there are two potential explanations. Number one, the drug tacrolimus is different than everolimus, so maybe they are not quite equivalent in efficacy, and maybe this is the case. But I think it's more important, in the study that you are mentioning, the patients did not have primary resistance to endocrine treatment. They were naive or still responding to endocrine treatment on tamoxifen, whereas mTOR inhibition is supposed, at least biologically, to reverse an existing resistance. The patients on Bolero 2 had a resistance to AIs, non-steroidal, and therefore steroidal AIs plus the everolimus gave us this clinical response. So it's a potential explanation.
So the window, at least for the moment, the data suggests the window for adding the mTOR inhibitor is not in first line. It's in the more refractory patients where perhaps there's a signal there. I want to go to another, not a common clinical problem, but an interesting clinical problem, which is the management of the patient who has ER-positive and HER2-positive metastatic breast cancer. So about half of HER2-positive tumors are also ER-positive. When such patients recur, they have a lot of choices, obviously. They have anti-HER2 therapies, they have endocrine therapies, and of course, chemotherapy. We know that there's crosstalk between those pathways as well. So what are the data for using endocrine therapy alone or endocrine therapy with anti-HER2 therapies in such patients?
So we have two good studies. One is about 200 patients, the other one is 240 patients.
I did one of these studies, a third one, wasn't that good?
It was outstanding. I'm still surprised you don't use more of it. Basically, what the question was, in these women who progressed after adjuvant treatment, were offered endocrine treatment, ER and HER2 positive, were offered endocrine treatment without or with a HER2 agent. One study was trastuzumab, and the other one was letrozole. And yours was lapatinib. Lapatinib, so the TKI, so the oral drug that inhibits the HER2 pathway intracellularly. And both studies show about the following. The endocrine agent alone gave the patient between 2 and 4 months time to progression. If one added either trastuzumab or lapatinib, it actually more than doubled. Trastuzumab doubled to about 4.8 months, whereas the addition of lapatinib was up to 7-8 months. So there's a difference of 4 or 5 months, which may or may not be important for the patient as long as the side effect profile remains low.
Well, and FDA gave a label to the use of letrozole and lapatinib based on that subset analysis. We in the CLGB did a study that I had the privilege of chairing, which looked at fulvestrant with and without lapatinib. And in the HER2 positive, ER positives, there was again a signal that there was a modest benefit favoring the addition of the anti-HER2 drugs. So is this something you do in routine clinical practice or not?
Well, I may be one of those who does. So I like doing it, particularly the combination of letrozole and lapatinib, before I start giving the patient with HER2-positive disease what they sooner or later will need, chemotherapy with trastuzumab, and then of course the whole array of compounds and combinations after.
Interesting. So I think my approach differs a little bit here. So we think about it a little differently. I got to say that when I look at the literature, most of the real magic for using these anti-HER2 drugs has been achieved in combination with chemotherapy. And I look at the data looking at combination with endocrine therapy as a more modest signal. So what I typically will do will be to try endocrine therapies, because there are some patients who actually do fine on just endocrine therapy alone. Not a lot, but there are some. And then if when they progress, add in the anti-HER2 drugs, typically with chemotherapy at that point. I like to see a response, and then I would reintroduce an anti-estrogen approach and maintain that with the anti-HER2 drug. But whether that's better is hard to know. I wish I knew beforehand who really needed that chemotherapy up front and who does not.
Yeah. I think that reflects exactly medicine. It's not a pure science. It's art, it's experience, it's also opinion. And your own experience may be different than mine, and it is. And at the end of the day, I don't think the patient will do better or worse with one or the other approach, just differently.
I'm glad you used the word art, because one of the points I always try to make to our fellows is that management of ER-positive metastatic disease is really about the art of oncology. It is about being patient, it's about trying things, it's about looking for clues one way or the other, but not overreacting. It's about pulling in a lot of different treatment options and using them in interesting ways, and I think that's one of the gratifying pieces of it professionally.
Yes, I agree.
Well, let me go back to our case question then and come up with some takeaways for this part of our discussion. The question was, in comparison to exemestane alone, treatment with everolimus and exemestane is associated with an increased risk of all of the following except hyperglycemia, stomatitis, fatigue, arthralgias, or pneumonitis and dyspnea. And the answer here would be
arthralgias.
Arthralgias. They're more or less the same in both groups. That's still an ongoing thing, these patients with the bone and joint symptoms. So here are the takeaways for our discussion of optimal therapy for patients with advanced or metastatic ER-positive breast cancer that is refractory to endocrine therapy. There are a variety of treatment choices. These include reintroduction of aromatase inhibitors or tamoxifen, use of fulvestrant, progestins, in some instances estrogens, and actually in an older literature, even treatment withdrawal. That's an old pearl that sometimes you can just give the patient a break and things will be stable for a while and occasionally even see a little bit of a response. However, there's a lot of scientific interest right now in strategies to overcome resistance. There's a lot of elegant science suggesting crosstalk between ER signaling pathways as they interact with both the mTOR and PI3 kinase pathways, as well as with the HER2-driven pathways in patients that have tumors that are ER and PR positive. And we now have compelling literatures that in certain settings, adding mTOR inhibition to hormone manipulation, or if the tumor is HER2 positive, adding anti-HER2 drugs to hormone manipulation can improve progression-free survival for our patients. There are trade-offs in the instance of the mTOR inhibitors in terms of side effects and extra medication. In the instance of the HER2-targeted drugs, obviously the inconvenience perhaps of intravenous therapy and some rare side effects. But I think that what we're all hoping is that we can begin to find circumstances where we can get more and more mileage out of endocrine therapies with relatively little downside. So that concludes our three-part community oncology debate series on advanced hormone receptor positive breast cancer. I want to thank you again for joining us, and we hope this activity has been valuable to you. I want to thank again Stefan Gluck, who's been joining me for these sessions and has provided some great clinical perspective. To receive credit for this CME video debate series, please complete the post-test and evaluation. Thank you very much.